medical experience journey and also how she's been getting like surgical procedures, like placements. So yeah, let's get started with Neha's presentation on appendectomy, please.
Hello everyone, and thank you for being here. My name is Neha, and today I'll be presenting on appendectomy. So, what is appendectomy? Appendectomy is a surgical removal of the appendix, whereby the prefix append refers to the appendix, and the suffix ectomy refers to the surgical removal of it. Why perform appendectomy? The main indication for appendectomy is acute appendicitis. Once appendicitis is suspected or confirmed, removal of the appendix is usually recommended. Surgery remains the most definitive treatments for this because it completely removes the risk of reoccurrence and it prevents complications like perforation. Appendectomy remains one of the most common emergency surgeries worldwide, and apart from appendicitis, it can be performed if the patient has a ruptured appendix or if they want it removed due to the belief that it has no essential function. This may be surprising to many. The appendix does have a known function, contrary to the outdated belief that it is a vestigial organ, meaning it is a small remnant of something that was once greater or has a specific function. This was backed up by the fact that it could be removed without causing harm, so is believed to be functionless. However, scientists now understand that it contains a high concentration of lymphatic tissue, contributing to the immune response. So on this slide, we're looking at the anatomy of the appendix, focusing especially on its lymphatic supply. The image on the right shows the lymphatic vessels and nodes surrounding the cecum and the appendix. The appendix itself is the small tail-like structure extending from the cecum. Although it's often thought of as a vestigial organ, its dense concentration of lymphatic tissue actually plays an important role in the immune system. It helps mature immune cells and contributes to the production of antibodies. The diagram at the bottom displays the arterial supply to the appendix, primarily through the appendicular artery and venous drainage through the appendicular vein. In terms of innervation, both sympathetic and parasympathetic fibers from the autonomic nervous system supply the appendix. These fibers travel via the ileocholic branch of the superior mesenteric plexus. The nerves accompany the ileocholic artery as they reach the appendix. To understand the nerve supply more fully, we need to look at the superior mesenteric plexus. This is a complex network of nerves that originates from the scoleac plexus in the upper abdomen. It carries sensory information from organs such as the stomach, liver, pancreas, and intestines to the brain. The superior mesenteric plexus follows the superior mesenteric artery as it supplies the small intestine, the ascending colon, and part of the transverse colon. The name superior mesenteric breaks down into superior, meaning higher, and mesenteric, which combines meso, meaning middle, and enteron, meaning gut, so it essentially refers to the upper middle intestine region. Clinically, this anatomy helps explain the pain pattern of appendicitis. The sympathetic afferent fibers from the appendix travels to the spinal cord level T10, thus explaining why the visceral pain of early appendicitis is felt centrally within the abdomen. Now, moving on to the pathopsychology, starting with malignant thyroid conditions. The most common type is papillary thyroid cancer, making up about 80% of thyroid cancers. It's generally slow growing and has an excellent prognosis. Symptoms may not appear right away, so diagnosis often relies on imaging and biopsy. Treatment usually includes thyroidectomy and sometimes hormonal therapy. Next is follicular thyroid cancer, accounting for 10 to 15% of cases. It develops in the follicular cells responsible for producing metabolic hormones. It's typically treatable but can behave more aggressively than papillary cancer. Medullary thyroid cancer accounts for 3 to 5% of cases and arises from the parafollicular Foci cells, which produces calcitonin. Its behavior is distinct from the other types due to its hormonal activity. Finally, anaplastic thyroid cancer is rare, less than 2%, but extremely aggressive. It occurs mainly in older adults and carries a poor prognosis due to rapid growth and early metastasis. Treatment often involves surgery, radiotherapy, and chemotherapy. On the right side of the slide, we have benign thyroid conditions. These include multinodular goiter, which can cause compressive symptoms like difficulties breathing or swallowing; Graves' disease, a common cause of hypothyroidism that may be resistant to medical treatment; toxic adenoma, which overproduces thyroid hormones and leads to hypothyroidism; and intermediate thyroid nodules, where cytology suggests possible malignancy but is not conclusive. These conditions relate to issues such as uncontrolled cell growth, overproduction of thyroid hormone, physical enlargement causing compression of nearby structures, or inconclusive cytology where malignancy can't be ruled out. Symptoms typically include abdominal pain that starts near the belly button then moves to the lower right, nausea and vomiting, loss of appetite, changes in bowel movement, or abdominal swelling. Examinations are also done, and these include McBurney's point tenderness, which tests for severe pain when pressure is applied to McBurney's point, a specific point in the lower right abdomen, which is a key sign of appendicitis. We also have rebound tenderness, which is increased pain in the lower right abdomen when pressure is applied, and this is a less specific version of McBurney's point tenderness exam. And then we also have Rovsing sign, which is pain in the lower left abdomen when the lower left side is pressured. There are two primary approaches. So the first one is open appendectomy, which involves a single larger incision in the lower right side of the abdomen to directly access and remove the appendix. And we also have laparoscopic appendectomy, which is a less invasive procedure where the surgeon makes several small cuts in the abdomen. A camera and special tools are inserted through these small openings to locate and remove the appendix. Laparoscopic appendectomy is the most preferred method, and there are advantages. For example, there's less post operative pain, smaller scars, faster recovery, and earlier return to normal activities, lower rate of wound infections, and shorter hospital stays. However, there are possible downsides. For example, there's a lower operating time, slightly higher risk of abdominal abscess in some cases, and it requires specialized equipment and training. So first, let's look at what happens before the operation actually starts. The patient is given a general anesthetic, which simply means they're put fully to sleep so they won't feel anything during the procedure. Once the patient is asleep, the surgeons create a small opening to reach the appendix. This can be done in two ways. So we have laparoscopic or keyhole surgery, and this usually uses three tiny ports, one near the belly button and two lower down. A camera goes in through one of them so the team can see inside. And then we also have open surgery. So this uses one slightly larger cut in the lower right side of the abdomen. The goal here is to simply get into the abdomen safely and move tissues gently out of the way so the appendix can be found. Next, the surgeon locates the appendix. So they look for the mesoappendix, which is a tissue that supplies blood to the appendix. They then free the appendix from surrounding tissues. This step may take a bit longer if the appendix is inflamed or has formed adhesions. They work very carefully because there are important structures nearby, like the cecum and small intestine, and they need to avoid damaging these. Once everything is clearly visible, they confirm where the appendix joins the cecum. Now that the appendix is freed, it needs to be sealed off and removed. So the mesoappendix is sealed, and this can be done with clips, stitches, or devices that use heat. Then the base of the appendix is secured so it doesn't bleed or leak. After that, the appendix is cut and taken out. The surgeons check the remaining stump to make sure everything is closed properly. A technique called stump inversion used to be common, but it isn't usually done anymore. After the appendix is removed, if the appendix was perforated or very infected, the surgeons may rinse the inside of the abdomen with warm fluid. This helps wash out any pus or contamination. Sometimes they may place a drain temporarily if there's a high risk of infection. Finally, the surgeons close everything up. They check that there's no bleeding, then close the deeper layers to keep the area strong and stable. The skin is closed with stitches, staples, or glue, depending on the situation. A clean dressing is applied on top to keep the area protected and dry. After the surgery, the patient is closely monitored to make sure they're recovering safely. First, the wound sites are checked for any bleeding or signs of infection, such as redness or swelling. The pain levels are also assessed regularly, so the medical team can adjust pain relief if needed. They keep an eye on how the gut is waking up after surgery. Things like bowel sounds or the patient passing gas are good signs that everything is working again. The patient is also monitored for fever because a temperature can be an early sign of infection. If the person has a catheter, the urine output is checked as well, which helps measure hydration and overall fluid balance. Pain is usually managed with medications like paracetamol and NSAIDs, and stronger painkillers like opioids may be used only if necessary. Antibiotics are given too, normally just a short course for a simple appendectomy, but a longer course if the appendix was perforated or the infection was more severe. For fluids and diet, patients usually start with IV fluids, then gradually move to drinking fluids, and then to normal food within 2 to 3 days as their gut recovers. Early movement is encouraged, so walking soon after surgery helps reduce the risk of blood clots and helps prevent the gut from slowing down, which can otherwise lead to something called ileus. Finally, the wound and any drains are looked after carefully. The wounds need to be kept clean and checked for signs of infection. If a drain was placed, usually only in cases where the appendix was perforated, it will also be monitored until it can be safely removed. Although appendectomy is considered safe, all surgeries carry risks. So the possible complications here include in the early days, you can get wound infection, which can be treated with drainage or antibiotics, bleeding from the mesoappendix or the ports, which may require return to the theatre, intra-abdominal abscess, which then can be treated with antibiotics and drainage. And there's also peritonitis or sepsis from perforation or stump leak, requiring urgent treatment. In the late days, you can get stump leak, which causes peritonitis and often leads to reoperation, adhesions which may lead to bowel obstruction, and port site hernia. In terms of procedure specific complications, you can get injury to nearby structures, or if you have to convert to open surgery, this can cause a higher wound complication risk. So to summarize, appendicitis is common and usually requires surgical removal of the appendix. Laparoscopic appendectomy is now the preferred approach in most cases. Risks exist, but complications are generally low when treated promptly. Recovery is usually quick, especially with minimal invasive surgery, and the best surgical method depends on the patient's condition and available resources. Thank you for listening.
Thank you so much, Neha. That was really helpful. We have the guest speaker now, Suwetha. So if she could share the PowerPoint that she has, that would be great.
Hi, can you hear me okay?
Yes, I can hear you.
Okay, cool. Let me just share my screen.
Your camera's not on though.
Yes, yeah. Just give me 1 second. I'll
Yeah.
do this first. Right. Okay. Should be able to see me now. Perfect. And can you see my screen?
Yes, I can see it.
Okay, cool. So, yes, thank you for that introduction. So, hi everyone. My name's Suwetha. I am a fourth year medical student at the University of Leeds. So today I'm going to talk to you guys a little bit about my surgical placement in uni, my work experience, which had a bit of surgery, and just generally sort of what I've been up to up until now, surgical wise. So, I'm originally from the West Midlands, from Coventry to be specific, and I applied for medical school in 2021 and took my A levels in 2022. I did a slightly different set of A levels to the normal person, I guess, normal medic, I guess. And I applied to the medical schools Leeds, Lincoln, Liverpool, and Lancaster, and applied to Brighton to do biomedical sciences with the view of going into medicine a year after because they had a transfer course. And then I got interviews from Leeds and Lancaster and offers from both of them as well as Brighton. And so now, as I said, I'm a fourth year medical student at Leeds. So that's me up until now as a whistle stop tour. So generally, I'm not going to dwell on this, but generally my tips and sort of things that really helped me when I was applying and I was able to put into my personal statement and talk about in interviews was I just joined loads of different webinars. There's all sorts of webinars out there for all sorts of things. I remember I did loads on antimicrobial resistance because that was quite a big thing at the time, but there's something for everyone. Essay competitions, there's loads. If you just Google like essay competitions, Cambridge do a ton of essay competitions that you can apply to and just send an essay in, and it gets you used to writing academically as well, which is always good and very helpful when you get to uni. Volunteering, sometimes they prefer volunteering to work experience because you can volunteer for a longer amount of time, and that shows that you're sort of committed to something for an extended period of time. So they really do like if you decide to volunteer. I volunteered at a primary school and in a care home, so those kind of things are really good. Any extracurricular you do, I bet you can link it back to medicine in some way, shape, or form. So no extracurricular you do is like not important. They're all equally important and have their own sort of skills. MOOCs, if you haven't heard of a MOOC, it's a massive online open course. So you can just sign up to them and it might be for like a few weeks and you do some teaching. So I did like a radiology one with the University of Leeds, which was really interesting. And read books, read articles, honestly, read anything and reflect on it, but I'll talk about that. So work experience. So if you decide and you're lucky enough to get some medical work experience. So I spent I think it was about a week and a bit in a hospital and I did lots of different things, including orthopedic surgery. Um, but thing is with work experience, it's really useful and you'll see lots of things and you'll get to see if medicine is a career that you want to do. But a lot of the time you won't get the opportunity to do much because obviously you haven't got the skills yet. So you will be mostly observing, but that's also fine and equally as important and as useful because you can just come across as approachable and friendly as I'm sure you all are, and just ask if you can chat to patients. Um, just get used to seeing the kind of things that they come in with, seeing the kind of things that worry them, because you can reflect on that and you'll get scenarios where you may need to bring in something that you heard a surgeon talk about, or you heard a doctor breaking bad news, and you're able to take sort of something that you saw in your work experience and use it there. So that's sort of my tips, and it's a really good way to network as well. So if you do work experience and you find something that actually you're quite interested in, just just ask, oh, like, I found this really interesting, do you have any ideas, if I wanted to do more of this, where I could find it, or would I be able to take your contact details in case I want to come back and do more, that kind of thing. Or the biggest piece of advice I could give is just ask, because the worst thing they do is say no and you move on and you find someone else. But most of the time they're very happy and willing to help you. Yeah, just ask and be eager. Don't pass up any kind of opportunity to see things or do things when you're on work experience, because you're not normally there for a long amount of time if you're there for on a hospital placement, just because they get very busy and they might not be able to accommodate you. But that's fine. Just always, ask to go see things. If you hear a doctor say, oh, I'm going to go see a patient on a different ward, just be like, oh, do you mind if I come along with you? Even when you're in medical school, always just be like, oh, do you mind if I come with you to do this? Or do you mind if I have a go at this, if it's something that's within your capabilities? And just ask questions. No, I know everyone will say this, but no question is a silly question. And the more you ask, the more you learn, and the more you come across as someone who wants to learn and someone that's worth them teaching, which is really important as well. So that's work experience. And I've just put this up there because I'm sure everyone knows the reflective cycle. So I'll only touch on this briefly, but whenever you do work experience, what I did was I sort of wrote like a bit of a diary entry. So I reflected on what I saw that day or what I did that day. And I just kept it in a book so that when it came to writing my personal statement or doing my interviews, I could just look back in my book and see what I wrote at the time, because obviously it's hard to remember everything you do and everything you see on placement. So keeping a note of that and reflecting, A, helps you gain the most out of it, and B, is what they want to hear you talk about in interviews or in your personal statement. There'll be thousands of applicants who have managed to get sort of like a few weeks in a hospital, but what will set you and them apart is what you gained out of it and how you communicate that by reflecting on what you've done. So it's not just keeping a diary of, oh, today I saw this procedure and it was really cool and nothing went wrong. Obviously that's great, but there's always something that could have been done differently, or something that will make you think, oh, is that something I want to go back and read about? So always reflect. And this is quite a complex reflective cycle. There are simpler ones, but this is the one that I found the most for. But okay, let's talk about medical school here in Leeds. So the first few years, we mostly did lectures, and it was a lot of scientific knowledge, all your pathology, all your physiology, all of that stuff you learn within the first 2 to 3 years. So there's a lot of knowledge, a lot of going back to the basics in terms of DNA and things, and then also some more in-depth stuff. So it can get quite overwhelming with lots of, obviously it depends what university you go to, the structure of the course and things, but we had lots of lectures, lots of small group teaching, and there was big books and textbooks and workbooks of all the sort of stuff that we needed to know at the time. So it can get quite overwhelming, but just try and get to grips with it as much as you can, because it will help you in the long run. So it's definitely worth just sitting down and trying to work through it. And then, so in terms of placement, so in Leeds, we actually do start placement from first year, which is unusual for most medical schools. Most of them start maybe third year onwards, some second year, but at Leeds we start in first year itself, and we spend half a day either in hospital or in a GP. And honestly, you don't really get to do much. What you do get to do is sort of talk to patients and just get used to the environment. A lot of the time, for the first few years of placement in medical school, you are just try not to get in the way. I feel like a lot of medical students say that, and you will hear that a lot, that I'm just trying to sort of let them do their thing, but watch and still gain things. And you can still get a lot out of it. So talk to patients. If you get put on a placement where actually there's something that you find quite intriguing, go back and ask if, like, can I see a little bit more of this? And most of the time they'll say, yeah, there's like a clinic on, or things like that. Just kind of get used to the environment in the first few years. And then go from there, because you want to be able to make the most of it when you get to the years where the placement actually, where you actually get to do things and actually get to see things that you might be more interested in. So the important bit, I guess. So my surgery placement. So I did my surgery placement at St. James's Hospital, which is one of the big surgical hospitals in Leeds. And I was in a general surgery placement. So you just had a talk on appendectomies. So a lot of bowel, a lot of GI area is general surgery's kind of remit. So yeah, lots of bowel, I was specifically in more lower GI. So sort of like bowel resections and things like that for Crohn's and ulcerative colitis, but I'll go into that a little bit more. And they were very long days. So surgery, you tend to start around 8. That's probably a general start, which I know if you guys are in school probably doesn't sound that early, but as a student, guess you have to get there and be ready for 8. And yeah, so 8 is quite early for us, and sometimes very late finishes. So I'll talk a bit more about the type of surgery that I was on, but some of the surgeries that I saw would only start at about 10 in the morning and finish at 2 the morning the next day, which is incredibly long and very difficult for them. But obviously, even for us as students, we do have to stay quite long, and they don't necessarily expect you to stay the whole time, but sometimes you just want to. And yeah, so you can have some very early starts and late finishes, but that's sort of the life of a surgeon. So it does get you ready for that if that's something that you want to do as a career. On my surgery placement, we did case discussions. So every week, a couple of different surgical specialties. So there was general surgery, breast and endocrine. There were 2 general surgery sets, breast and endocrine, and another type of surgery now that I can't remember. But there were a couple of different surgical specialties. What we all did is we all came together and we'd pick a case that we saw that week, and we'd talk about the procedure, talk about the management, talk about what might have went well in that case, what didn't really go so well. And basically it was like a group reflection exercise. And if you do like a surgical work experience or have a surgery placement in uni and they don't do a case discussion, I would recommend sort of running your own kind of case discussion thing. So picking a case that you see in that week or that day, and then like dissecting it and talking about sort of what the good points were, what you learned, what you need to look at further, any research that can be done in that field. And then you might even be able to ask beforehand, oh, can I like present this case to you that I saw, or can I discuss this with you? And you'll get a lot of learning out of that. So that's something that I would recommend doing. And a surgery placement in uni, and even if you do a surgical work experience, is not just theatre time. As fun as theatre time can be, it's really important that you spend the time on the wards and the clinics. So wards, they'll have like a pre-operative ward and a post-operative ward, and it's good to spend time on both because you see sort of a lot of the anesthetic stuff beforehand. So you could go along with the anaesthetist and see how they check the airways of patients before they put them under general anesthetic and how they consent them. And sort of a post-operative ward, so looking at sort of how we're going to get them mobile, how we can get them sent home if they need anything extra before they go home. And clinic, so clinic is a lot of we might see people before they're having surgery to talk to them about their surgery, make sure there's anything that we don't know, that we clear it up. And we also see people after surgery, like a few months afterwards, to see if everything's going okay, if they're healing, if they've had any extra problems. So before, during, and after for surgery, because you need to know about all of it if you do want to do surgery as a career, I guess. So I was in a very specialist surgery. So I mentioned I was in general surgery, which is a lot of bowel, but I was quite lucky. I got the opportunity to see this, which is called pelvic exenteration. So they currently only have 2 surgeons in Leeds who do it and 1 who does it down in London. So it's specialist. What it is for people with kind of bowel cancers that are a little bit aggressive, what they try to do is kind of take out anything that is affected and could be effective. So here you can see they'll take out bladder, they'll take out the rectum, they take out all of, if it's a female, they'll take out all the uterus, cervix, and vagina, and they just take it all, and you're just kind of left with this cavity, the abdominal space. So it's really interesting and it's quite a radical surgery. And it's not sort of a life-saving surgery in that people are going to necessarily live years and years and years without basically nearly all of their abdominal organs, but it's a really good surgery for people to give them an extra few years of life that chemotherapy or radiotherapy wouldn't have been able to offer them. So it is as radical as it sounds, and if you do get the opportunity to see it, as radical as it looks, it's actually really quite a successful surgery if it does go well, because it gives patients those few years to sort of have with their family and friends in the situations where they have quite an aggressive bowel cancer. So it was really interesting to see, but quite crazy, sort of when you're looking at it, when you just see them taking this, that, and the other out, and it was very, very cool. But obviously, because it was a general surgery placement, I did see other things that weren't quite as long, fun, and radical, I guess. So laparoscopic laparoscopic colectomy is for IBD. So as I mentioned earlier, like Crohn's, ulcerative colitis, if people have really serious disease spread, then they might take out that section and either form a stoma, or like you can have a hemicolectomy, or you can have it where they sort of do a temporary kind of stoma, and then with the view of going back to fix it in a few months time, so rejoin the bowel so they don't have the stoma. You can also have it so they put a mesh over it to stop any hernias from forming. So if any of the bowel comes out of the stoma site, they can put mesh in to stop it from coming out. So they're also really helpful surgeries and really cool surgeries to see. And yeah, so clinics, as I mentioned earlier, you have them to counsel for procedures, and also because general surgery is quite, well, I mean, the bowel is quite closely linked to uterus and endometrium and things. So endometriosis surgeries, where they do remove sort of endometrial polyps from different places that they might have spread, they need bowel surgery. They need bowel surgeon input to make sure if there are any that are sort of invading the bowel, then the bowel surgeons will come in and they'll have a look and make sure that they're not cutting any bowel they shouldn't be or perforating it. So that's what they're there for. So there's a lot of things that general surgery kind of touch on, kind of cover. It's quite a big sort of branch of surgery. If it is something that you're interested in, there's a lot of different things. You can go from upper GI, lower GI. You can specialize in endometriosis. You can, you might be able to learn how to do a pelvic exenteration if you're super lucky and super interested in that. So there's a lot you can do when it comes to general surgery. So I'm going to talk about sort of the positives of that surgery placement and some of the negatives that I experienced, just to give you sort of a well-rounded view of what placement can be like, and I guess kind of tell you what things I wish I knew before I rocked up to my placement in third year. So there was lots of opportunities to scrub in, and if anyone ever asks you, do you want to scrub in, always say yes, because that's where you see the most, unless it's laparoscopic, where they have the TVs up so you can see from wherever you want. Scrubbing in means that you can get close to the patient, you can touch the sterile field. So I was lucky enough to get the opportunity to scrub in for, I think I saw about 4 or 5 pelvic exenterations, and I think I scrubbed in for 3, which was pretty good. And you get to see the anatomy up close, so you can see all the vessels and all the sort of nerves, and you can see the structures within the cavity and within the patient. So that's a really interesting thing, and it's a really good way for you to put the anatomy that you see in the labs, whether you do prosection or dissection, to see it in an actual alive patient when it's sort of the colors that it should be, and you can see it in the context of everything else. So it's a really good way, if you're really interested in anatomy, really good way to be able to see that. Wards were really good to practice skills. So when you start medical school, you'll have to do skills like taking bloods, putting in cannulas, that kind of thing. A lot of that happens on a surgical ward because everyone needs a cannula before they go into surgery to give them the anesthetic medications, things like that, and take bloods from, etc. So everyone's going to need a cannula. Everyone's going to need bloods. So we do sort of routine bloods, so like full blood count, checking all their red blood cells, things like that. And you do kidney function tests to make sure their kidneys are working. And you also do something called a group and save if they're about to go to theatre. And what that is that's a blood test to check what blood type they are in case we need to give them a transfusion when they're in surgery. So basically what I'm saying is there's lots of opportunity to take some bloods if that's something that you want to practice and want to get better at, and there's also lots of other skills that you can do, and there's always a lot going on surgery. There's always never a dull moment. So there's patients who have just come back from theatre, patients who are about to go home, patients who are about to go up, so you can go and talk to a lot of them. A lot of them will be quite bored if they're post-op because they might not be mobile yet, they might not be able to go home, so they're always happy to chat to you, especially if they've had a successful surgery. I'm sure they'd love to tell you about it. So you can talk to people and there's always a lot to see, and especially in Leeds where it was such a big hospital, there's always some kind of procedure going on somewhere, so it is good to see that as well. You might be able to see a couple of different other surgical specialties, so that can be quite good. The negatives of surgery is, you might hear people say this, but it is quite a cutthroat environment, some might say. It can be very intense and it's very difficult to become a surgeon. It's definitely not an easy thing. So they are quite serious about their jobs, as they should be, because they have quite an important role. So it might be that people don't want to talk to you sometimes. People don't want to have a medical student with them because they just kind of want to concentrate on their job that day, which is completely fine, and you have to understand that, and you have to sort of take it on the chin and not take it personally, because not everyone can scrub in for every single surgery. If that was the case, then it would be a lot easier. So sometimes you do have to, put your foot down. If there's something that you really want to see, then just ask and be like, I really want to see this. Would you mind if I scrub in to do this? So be really forward with your surgery placement, because that's the way you're going to get the most out of it. It doesn't tend to fall in your lap, whereas it might for some other placements. As I mentioned earlier, there were long, tiring days. So I think sometimes I'd get in for about 8 and I think I'd leave at 8 p.m., 8:30. So it was quite a long day on placement. Then I have to come home and, get ready for the next day. So yeah, they can be quite long, but they are quite rewarding days. So it is worth it. I wouldn't have done it if I didn't find it was worth it. So as much as they are long and tiring, they're definitely worth it. And it can be tricky to get good placement teaching. So when I say that, I mean like on the placement itself. But that's purely because, as I mentioned earlier, people are busy, um, and they might not notice that you're there or you want something. So if you have a question, just ask, oh, do you mind if I ask something quickly? And just try and be proactive about it and try and get the most out of it that way. You might not necessarily learn the most, like pathophysiology. Wards are a really good place to learn that stuff, but in theatre, you can't really be asking, oh, so how does sort of Crohn's disease progress? Well, like they're in the middle of surgery, they're probably not gonna be able to answer you the best they can. So that's just something to bear in mind, that you have to sort of time it right if you have got things that you want to ask or you want to find out more about. But yeah, overall it was quite a positive experience for me. So I don't mean to put you off, but just to give you guys a rounded view of sort of my time there. So I mean, I haven't just done general surgery. There are lots of other surgical specialties, as I mentioned. One of which, so I recently, just a few weeks ago, finished my obstetrics and gynecology placement. So there was a lot of elective C-sections, but it's not just that. You can have emergency C-sections as well. They tend to be maybe in the middle of the night, or even, to be honest, just during the day when something goes wrong when giving birth. Forceps deliveries, that's also done in theatre, so you can see that as well. And hysterectomies, so gynecological surgeries, so endometriosis surgeries, as I mentioned earlier, hysterectomies for women who have completed their families. So they're also really cool surgical experiences. ENT and ophthalmology, so ENT, very intricate sort of head, neck kind of region, very sort of looking at all the nerves in the facial structures and things. That's really interesting. Ophthalmology specifically is microsurgery, so everything's done with a microscope, tiny, tiny sutures, which is really interesting to see. And it's a very different surgical special. It's still a surgical specialty, but you get a bit more of a medical mix if that's something that you're after. But the surgeries for ophthalmology are very intricate and very, very, very tiny, because obviously it's all in the eye. And then you have orthopedics. So that's kind of the complete opposite to ophthalmology. So you've got lots of hammering, lots of like maneuvering of like the limbs, and I saw lots of hip replacements, lots of knee replacements, very sort of intense surgery. And that's also what I saw on my work experience as well. I got to see some orthopedic surgery there. Not quite hip replacements. It was a guy who had been kicked by a horse in his leg, but he didn't realize, because he had diabetes as well, so he had a loss of sensation in sort of his feet, but he didn't realize that his leg had been broken for some time. So we came back and we fixed that for him. So that was quite an interesting surgery, but you got to wear sort of lead aprons because they're taking lots of x-rays. So quite a sort of more intense surgical specialty, I guess, but also very, very interesting. So my tips, I've kind of mostly touched on that, but yeah, be really proactive. Surgeons are very busy, so you need to show that you're there to learn and you're there because you're actually interested and you want to do something and you want to get something out of it, because otherwise they have very busy lives and probably would rather be doing other things. Always ask to scrub in. You may be able to see, you will be able to see more. You can get closer, you can sort of have a closer look at what's going on, and they may even let you help. So I got to suture, I got to cut some things. I get, it's all very little things, but they are quite fun, and they're a good way for you to practice your suturing skills if that's something that you know how to do. Always go to clinics as well. Clinics are a good way to see how the surgeons communicate with patients about post-operative care, pre-operative care. So they're equally as important as the time you spend in the surgery and in the theatre. And read up before you go to your surgery placement, because surgeons love to quiz their medical students, especially on the anatomy. If they see a vessel, the chances are they are probably going to ask you what the vessel is. So you would like to know. It makes you feel a bit better if you do know. So read up on the anatomy if you know what kind of surgery you're going to see, or even sort of the reason why they do that procedure, so that you know if they do ask. And yeah, just make sure you know your stuff generally as well. But yeah, I think that's it for my experience. A couple of tips, I guess. For you guys, if you are looking to do surgery. So I put the pathway up here, but I'm sure you guys have seen it before. But you do your medical degree, do your foundation year as everyone else will, and then you sort of do your core surgical training, and then you can go into your specialist training, and then eventually you'll reach consultancy depending on how long sort of the training pathway takes you, and you can take breaks and things like that and research. But you want to start building a portfolio as soon as you can. So as soon as you figure out what you think might interest you, speak to doctors in that specialty, whether it's registrars, consultants, just talk to them, ask them sort of what they did when they were applying, and anything like that. Get contact details. They might even be happy for you to contact them as like a mentor thing to sort of sound things out, or like help you figure out your pathway, and they'll be able to help you sort of guide you in the right direction. Try and get research experience. It's really hard to do, I will admit, but just send out a few emails if you meet someone on placement that you think, oh, like, if that's something you're interested in, I might be able to, get some research experience with them. But at least look like, you want to do it, and they are more likely to help you if you seem like someone who wants to be there. And if you guys haven't heard of one already, but you can start a surgical logbook. So what that is if you just go onto Google and type in surgical logbook, it will come up with like this website. And what you do is every time you go into theatre, you can write out what you've seen, what you got to do. And it's good to start keeping a log, because that will help with your specialty applications as well. And as I mentioned earlier, case discussions are really helpful. Even if your placement or your uni don't offer them, they are still really useful for your learning as well. And yeah, that's everything. So thank you all for listening. Thank you for having me. My contact details are here. My email is here. If anyone does want to contact me, or I'm happy to take any questions now, I'll try my best to answer them. But yeah, that's everything for me otherwise.
Thank you so much, Suwetha. I do have a couple questions for you.
Yeah.
So, like specialty surgery that you talked about, what were your reflections for them? So, the specific surgery you talked about, what did you learn from it? What were your like reflections, maybe using the Gibbs cycle that you talked about? I just want to learn some personal reflections.
Yeah. Are you talking about the pelvic
Yes,
exaggerations, like
yes.
this surgery? Okay, cool. Yeah. So, what did I learn? So they, as I mentioned, are quite big procedures, quite difficult procedures. So as I said, it's for sort of radical cancers, and they're quite sort of time intensive and labor intensive. So what I guess what I learned from that is probably some of the good things was the way that the team worked was really, really effective. So obviously you're keeping a patient anesthetized for so long. So you need to communicate with the anesthetist if anything goes wrong. There's a lot of blood loss associated with this surgery. So they need to monitor that. Then you also have your scrub nurses who will get tired as well as you as the surgeon. It's very tiring. You need a couple of pairs of hands, but you don't want all your pairs of hands to be doing the same thing at the same time because that gets chaotic, right? So the communication was so important in those moments. Being able to communicate if something is out of your remit or if you're really struggling with something, it was so important that the surgeon said, actually, I don't know if I'm fully confident making this cut or, going for this. Because obviously in this surgery, you're very close to the bladder, the ureters, things like that. They're very delicate structures, right? So you don't want to sort of mess up and accidentally nick something. So knowing your remit and being able to say, actually, you know what, this is too much for me was something that I learned and was really important in that surgery. So yeah, I guess some of the negatives and the things that I would, you know, maybe take forward into my practice, I guess, is, I mean, it's quite, it's difficult to be up there for such a long time and do this for all this time. And as you do go on, you will get, tired and you will be more prone to make mistakes. So I think for me personally, being able to communicate, actually, I don't I don't feel comfortable going to do this bit now is something that I personally would like need to work on and make sure that I'm not working outside my remit, as I mentioned. They were really the surgeons who were doing it were really good at acknowledging that, but personally as a student and even as a trainee, it's something that you'd really want to prove that you are worthy of like being there, but also knowing that boundary, even as a medical student generally, not in surgical specialties, knowing your remit and making sure that you don't work outside your capabilities is something that I would definitely like. I've definitely started thinking about more since after my surgical placement. Hopefully that answers your question.
Yeah, basically not trying to overwork yourself, if you have the potential of actually damaging the patient in a
Mm.
sense, just knowing when to stop and your limitations
Yeah.
and the fact that you're human as well. Yeah, I get
Hmm.
that. How I'm not sure if you mentioned, but how long was your surgical placement for this one?
So this one was 4 weeks. We did 4 weeks of general surgery. Yeah.
So during this time and during like all the other work experiences or placements you were on, did you have to like study? Did you have to join the lectures that your medical school like hold, or did you just have to focus on these work placements?
So for this surgery placement, we had sort of teaching integrated within it. So we'd have
Yeah.
like clinical skills sessions where we do like simulations of acutely unwell patients, things like that. But at the same time, we have sort of this was in my third year where we start the MLA content, which is the licensing exam you take at the end of medical school. So you need to start working on those conditions. There's about 100, no, just under 200 conditions that we need to know it by the end of third year. So obviously, I need to come back and start, going through those conditions. So yeah, I had to balance. It wasn't necessarily university lectures, but there was placement teaching, in terms of like skills, but also sort of written knowledge for the written exam. Yeah.
So how did you manage that with the long hours you mentioned? How were you doing it in the morning or after you came back or in the middle? How were you doing it?
Yeah. So I would, because so this was like a hospital in Leeds. So while I was on transport to the hospital, because there was a shuttle, I would do a bit then, and then I would get to the hospital a little bit early, um, and I would just do some work in the morning. sort of maybe go over the things that are more related to my placement. So I would always, when I was doing my general revision, I would pick sort of the conditions that we needed to know that related to this. So all of the Crohn's, any of the sort of GI conditions that we needed to know, I sort of tried to work through during this placement, because I always find it really helpful when I'm on a placement and I do a sort of set of studying to link the two. So I try and do the studying associated with the placement. So I do some then. Normally lunch I would be with sort of the friends I had in the on the placement. So I'd use that time to just socialize. And then when I came back, if it wasn't too late, I would do a little bit more work while I after I had some downtime while I ate my dinner, and then would go to bed and start again. It was difficult and the weekends were really important, but it is manageable. It's definitely manageable.
All right, thank you so much. Those were all the questions I had. But yeah, thank you for coming on, and apologies for the not that many people actually showing up. It
Oh,
was
that's
really, really
okay.
helpful
Good. I'm
for the
glad.
patient for the people that did turn up. But yeah, thank you so much. I'll be sending
No,
you a feedback form for the like a form that you had to fill out, just so I could know if there's anything I should be improving. And yeah. So yeah, thank you for coming on. It was really, really helpful.
no,
Thank you so
thank you for
much.
having me.
No
Good.
problem.
I'm glad.